Hello, how are y'all doing? Sorry it's been such a long time since I posted because it's been crazy busy for pathology residency. I am graduating pathology residency tomorrow, so yeah. Anyway, my name is Jay Huang. I'm a fourth year pathology resident in the States, and I go over cases almost on the daily from head to toe. So if you're interested in that, please give a like and or subscribe. Without further ado, thank you to Path Library for this case. All right, so this is an oral mucosal lesion, 60-year-old male. So what do we see here from low power? We see elongated reedy ridges, right? So these are reedy ridges, these elongations of the epidermis. And they're, elongated. They're longer than usual, and it has equal elongation, right? It's not irregular. So first thoughts, back of my head, maybe this is psoriasis. Usually you don't see it in the oral mucosal lesion, but if this were like a skin lesion on an extensor surface like elbow, I would think, psoriasis. I would think maybe there's newts in the stratum corneum. But this is oral mucosal lesion. So let's delve closer, okay? So we have just normal stratum spinosum here with these, within the stratum spinosum is these keratinocytes, and you can see there's a little bit of edema because you can see the intracellular bridges, mild, not great. And then in the top part of the epithelium, including the stratum corneum, you see dead cells, right? Or cells that are undergoing death with apoptosis, karyorrhexis, pycnosis, right? But you have cells that have naked nuclei. And it's a sharp transition from the top third to the remaining area of the epidermis. So this is mechanical epithelial injury. And the histologic hallmark of mechanical injury, both in the skin and mucosa, is a sharp transition from viable epidermis here to a layer of non-viable keratinocytes with pink homogeneous cytoplasm. You'll have clear spaces in which nuclei of days past were previously located, and these are just dead keratinocytes. In the skin, this change is usually secondary to scratching, itching, although it can be seen in superficial burns. The changes in this case were probably due to the patient's history of chewing, tobacco use. And then in the dermis, in the reticular dermis, you see some perivascular hyalinization of the vessels, which is likely another secondary change. Features of mechanical thermal injury are important to recognize so as not to confuse with inflammatory conditions like I had mentioned, psoriasis. There may be a wide variety of accompanying findings including lymphocytic or neutrophilic infiltrates, spongiosis, and dyskeratosis, but these changes should not be interpreted as evidence of a specific disease entity in this setting. Mechanical thermal injury is characterized histologically by an abrupt transition from viable to fibrinoid necrosis. Now, if the whole epidermis was necrotic, then you would want to think of a more serious and sinister etiology like 10, toxic epidermolysis, epidermolytic necrosis, and on that spectrum with Stevens-Johnson syndrome. Okay, I will see y'all another time, and take care. Bye.